evening, and thank you for joining us. We have a bit of a different show for you tonight. I'm Anita, Bathe, host of CBC Vancouver News at 6, and with me is Belle, Puri, who over the past few months has been leading our coverage of BC's healthcare crisis.
This is Situation Critical, a CBC virtual town hall about the issues British Columbians face when it comes to healthcare.
Tonight, we are live, online, on TV, and on radio. We're here to hear from you and to give you a voice to your stories, hear your concerns, and ask your questions. Close to 1 million British Columbians don't have a family doctor. Let's look at some of those critical situations and the reasons for this special town hall tonight.
Almost like we need Doctors Without Borders in Victoria.
My emergency room and my hospital is at absolute record overcapacity.
I place the ad because I need a family doctor.
They have been working extremely hard in conditions amidst the pandemic, the opioid crisis.
Surely there's a compassionate doctor out there who will hear my appeal.
I'm angry at the people who get paid to look after the system, who aren't doing their job, who allowed it to get to this condition.
When will the minister end the empty rhetoric?
So my cancer had been incubating for roughly 2 years, and in that time frame, I wasn't given the chance and the prompting through a physician to catch it early.
And if it's just continue on status quo, and it's what the provinces are, we need more money from the federal government, that's going to solve the problem. I'm not down with that. Like that's not going to work.
Over the next 60 minutes, we'll take a hard look at the shortage of family doctors, emergency department closures, and the challenges of recruiting and retaining healthcare providers in this province.
We have 3 panelists with us tonight. Adrian Dix is BC's Health Minister. Dr. Monique Desange is President of Doctors of BC. Dr. Rita McCracken is a family physician, a primary care researcher, and an assistant professor at UBC's Faculty of Medicine.
We have our questions for the panelists, but most importantly, we want to hear from you, our audience. What has your experience been accessing a family doctor or emergency health care in BC? Has it been positive, negative? What answers do you need tonight from our panelists?
Give us a call, toll free around the province, 1-800-825-5950. In the Lower Mainland, 604-669-3733. You can email bcasks@cbc.ca or message us on Twitter and Facebook.
As we wait for some of your questions to come in, we don't want to forget about the news of the day. So CBC Vancouver News at 11 host Dan Burrett is standing by with our top headlines.
Good evening. A homicide investigation is underway in Surrey after a man was found passed out and injured inside a running vehicle this morning. Surrey Mounties say the officers found the man unresponsive just before 9:30 a.m. along 127th Street near 88th Avenue. First responders tried to save him, but he died shortly after. Police haven't yet said how the man was hurt. Anyone with information is asked to contact police. Lumber company Canfor is cutting production at most of its BC sawmills for 2 weeks. The reductions start next Monday. The company cites reduced demand due to rising inflation and interest rates. It says employees will be able to work on maintenance projects during the downtime.
Our current levels will drop fairly significantly by the end of the month, but we'll still see bouts of activity here and there, and depending on how the weather.
And the fire danger rating in BC's Coastal Fire Centre has dropped enough that campfires are once again allowed. The BC Wildfire Service says the cooler weather and rain has helped. There are now 176 wildfires burning in BC, with one fire of note, the Battleship Mountain Blaze in the Prince George Fire Centre. Evacuation orders for Hudson's Hope were lifted over the weekend. And we'll have your latest local news tonight at 11, right after the National. Now, back to Situation Critical.
Welcome back. You are watching Situation Critical, a town hall to look at the state of healthcare in British Columbia. 1 in 5 people in BC doesn't have a family doctor. Until recently, Janet Mort's husband, Michael, was one of those people, and Janet went to great lengths to find him a physician.
Michael's life was in my hands.
I'm afraid I have a terminal disease.
We lost our family doctor when at age 75 he decided to retire, and certainly he had every right to do so. He was a geriatric specialist and he was exactly what Michael needed. So his loss was very hard on us. So we started with TELUS Health and relied on TELUS Health 2 or 3 times when Michael needed medical care. Michael had been having some new symptoms that led all of us, including the TELUS doctor, to believe that he had a serious prostate issue. It became urgent that we get a family doctor. There's no other way to describe it. And that night, I was awake all night because I realized for the very first time that Michael's life was in my hands, that there was nobody else that was going to help him except me. And all I could think of was go public. Surely there's a compassionate doctor out there who will hear my appeal and squeeze him in as one more patient. So I woke up in the morning and asked Michael, are you ready for this? Because once we do this, everyone will know your medical condition and the struggles we're having. And Michael said yes. That Saturday, the ad was in the paper, and within 2 days, Michael had a family doctor, and he's being so well looked after. The referrals are all in place. All of the additional tests have been done.
And if it weren't for Janet, I would not be here today. She has saved my life. I love her, but I also really appreciate that she has kept me alive. And our lives continue to have opportunity in the future.
That's Janet Mort and her husband, Michael, from Victoria. Let's bring in our panel, starting with BC Health Minister Adrian Dix. Minister, we just heard from Janet and Michael. It's not a unique story. Hundreds of people will tell you something quite similar. What does it tell you about the type of job your government is doing when it comes to healthcare?
Well, we've been in a crisis. People talk about a healthcare crisis. We've been in a healthcare crisis for a number of years, a public health emergency, in fact, with COVID-19. And that's affected, for example, primary care more than anything else. In March of 2020, that end of year, 98% of our primary care visits were in person. After April 1st, the year that followed, it was 30%, which is the most radical change in the way we deliver primary care we've ever seen. At that time as well, really between 900,000 and 1 million people were without a family practice doctor. So we've taken a series of measures then, and we've got to continue to take them now to ensure that that generation, our current generation, people needing a family doctor now, can access appropriate care, and as well that we build for the future, because we know that in 10 years there are going to be twice as many people over 75, who have a greater need for healthcare than people younger than 75. So demand isn't going to slow down, and that's why we're taking all the steps that we're taking to address the situation. It's a significant challenge.
No one disagrees. This is something that has been percolating over years. But your government is not a one-term government. You've had time to put some changes and fixes into place, yet it seems like more and more people are saying, I don't have a doctor, or I can't get in to see my doctor.
Very significant demand in our healthcare system, so we have to take steps to respond to that. We've added 60 new residency places, and we have the largest family practice residency program in Canada. We were last in Canada when I became Minister of Health in registered nurses. We've led the country in new registered nurses since then, and added net. This counts all the people who've left the system, 38,000 new people. But here's what's true, that demand is significantly higher, in part because of the pandemic, in part because of the aging population, in part because of all the people who've come here. And we need to respond to that, and that's exactly what we need to do. We've taken action, and I think you see this in all the areas where we've been working on surgical care. You remember, we delayed all non-urgent surgeries in March and April of 2020. We got down 35,000 surgeries, and in the pandemic, we've done more. And we've got to take the same approach in this case
Okay,
Recruiting more doctors
we'll let you get back
and
to
making
that.
life
Let me
easier with
just
more
get
doctors.
to some of your panel members here. Dr. McCracken, you know, a lot of people also talk for fee-for-service model that it's outdated. What would a new system fix? You know, would it guarantee British Columbians getting family doctors?
Well, I mean, I think at this point it would be foolish for anybody to say I have a guaranteed solution. There are no short-term fixes that are going to magically make this all go away. It would have happened by now if that was possible. But I think the fee-for-service system is a really interesting and important element to talk about. Imagine if we had 1 million kids who didn't have access to schools, and we were relying on a group of teachers who were paid per child, per lesson. And we can see quite clearly that it's going to be pretty hard to get them all involved in solving this shortage. And so being able to organize physicians and incentivize the behaviors that we want is what we need to do.
We'll talk about that a bit more through the hour.
Okay, we want to get now to a phone call because we've gotten a lot of emails about the role of nurse practitioners in our primary care system. And nurse practitioners can assess, diagnose, treat, and refer patients to specialists just as family doctors do. Nurse practitioner Sarah Jesshope wrote us. She's at Healthcare on Yates in Victoria, which is a clinic led by nurse practitioners and not family doctors. Sarah is on the phone now. Sarah, what would you like to say?
Hi, Anita and Belle, Minister Dix, Dr. McCracken, and Dr. Desange. I'm so glad to be here and be able to speak tonight. Thanks to the Ministry of Health, we were able to realize our nurse practitioner-led clinic proposal over 2 years ago now. Our team provides comprehensive, high-quality primary care services to over 4,000 patients and counting. We are 6 nurse practitioners, 5 registered nurses, a mental health clinician, a social worker, and as of a few weeks ago, we've welcomed 3 pediatricians to our team, which is wonderful. I think our clinic is an example of how collaborative practice across health disciplines can work together to meet patient needs and decrease barriers to primary care.
Okay, we'll leave it there. Thank you, Sarah Jesshope, calling from Victoria tonight.
Dr. Desange, what about nurse practitioners? In your eyes, what's their role in fixing or helping remedy this crisis?
Absolutely. Thank you, Sarah, on the phone. I think they've been a testament to providing primary care access and collaborative care efforts to be able to help mitigate our crisis. And I absolutely think that nurse practitioners are vital to our team-based care. I do not believe that there's any way that we cannot do this without a team, and it takes all of us. I've worked alongside many nurse practitioners and delivered seamless care, but we have to be able to think about the amount of nurse practitioners we have. We'll not be able to take care of 1 million patients right now without a physician, and I think this is why we want to rely on collaborative efforts, and there have been many examples in which, as Sarah has told and illuminated, that there are many aspects of care that thrive in these kind of environments. And while we have the 3 of us tonight here, I do think it's really important to include a patient voice and to really ensure that we are setting up something to thrive. I think all British Columbians deserve the best type of healthcare that we can provide. And we know that's going to take, there's no short-term fix. Dr. McCracken was right with that. But I think if we try to set out some medium-term and long-term stakes, and that I think it's really important to acknowledge Minister Dix and the NDP government, but I also want to acknowledge all of the other parties that have been vocal about our healthcare crisis. I do think that if we think about things differently and have an opportunity to innovate, we all can agree on one thing, regardless of our parties and our nonpartisan approach. But if we look and commit to healthcare and its delivery, it's going to take all of us.
All right, Minister Dix, I want to talk about urgent and primary care centres. When they were introduced, I remember, we did the stories about they were part of the solution. But let's check out this email from Germaine Bersanger in Cranbrook. No family doctor for years, so she turned to a UPC centre and now writes, it is often short-staffed. And when I tried to fill a prescription a few weeks ago, I was told it would be a 5-hour wait, the notice on the window. said due to staffing shortages, appointments will be limited today to urgent visits only. So, Minister, it sounds like they're having the same problems that we're seeing across the system. I mean, how are they going to work if they're not adequately staffed and people are still waiting hours or days?
Well, in terms of urgent and primary care centers, they've been, first of all, vital in the pandemic. When we went away from in-person visits, they were open. And 1.5 million visits shows that there's both a demand for them and a need for them. 450 people work in urgent and primary care centers. It's team-based care. Of course, family doctors are at the center of that, but also nurses and nurse practitioners and experts in mental health and addictions care. So some of them, particularly the ones on Vancouver Island, have had the staffing some of the staffing issues you've talked about. In general, in other places, they're staffed up. But we've been asking them to do a lot, I'd say. They've been open for in-person visits, and they provided that very significant care at a significant moment. But I think here's the point. We started nurse practitioner-led clinics. You heard a little bit about that. We've worked through primary care networks, which have been led by local family doctors, added in total through our primary care networks 1,200 new staff people to those. And urgent primary care centers, there are 27 of them out of 2,000 clinics in BC.
There's lots of numbers,
and they're
Minister.
playing. Well, but no, but,
I know,
but think of the patients, though.
Yeah, we
In
are
that
thinking
case,
about
Belle,
the patients. That's why we're
1.5
here
million
tonight.
visits is 1.5 million people getting care. And so I think one of the challenges sometimes we say, well, urgent and primary care centers haven't solved the whole problem. They were never intended to. There are 27 of them in all of BC. They're part of the solution, but we're going to need a number of actions, like using all our health professionals and like supporting our existing family practice clinics to allow them to make sure that they can operate both financially and provide the best possible care to their patients.
We have to leave it at that point. Thank you, Minister, for that. This is situation critical, a CBC town hall to look at BC's primary care health crisis.
Yes, and if you're watching us on TV, we'll be back after a short break. But for radio and our online audience, we are staying live, so stick with us. Let's turn to a comment now from the Interior. Darcy Ulmer is a self-employed husband and father who moved from Squamish to Lumbee in the past year. He has 4 children under the age of 10 whose mother is in remission from cancer. They are all without a family doctor, a fact he says is most risky for his immunocompromised wife.
That situation just is not acceptable for us. And the implications of something slipping through the cracks because we're not getting continuity and regular care, that could be catastrophic for my family. You can't even get through to a receptionist in the doctor's offices in Vernon. They say right up front, we're not accepting new patients right now. So you're left with the urgent care centers, which I fully acknowledge, and I think that they are that they help, and I've availed myself of those services and been very satisfied with the results. But again, I don't think they're a substitute for a family physician for our particular case, especially in my wife's case. The bottom line is we need to start thinking outside of the box, like the status quo, and saying that we're going to solve it by getting more money from the federal government. Like, what planet are you on? That's not going to work anymore. We accept tiered education. There's private schools all over the place. We accept that. We accept tiered housing. There's affordable co-op housing, and some people live in gated communities. We accept that, and yet I can't choose to purchase healthcare for my family the way I want to choose. And so the alternative is I have nothing.
That's Darcy Ulmer in Lumbee tonight. He's a 55-year-old father of 4 whose wife has survived cancer, and he wants the option to pay for private care. Now, we are sticking with this theme a little bit right now. Belle, I think you have another email to show us. It's from Agnes Rue.
Yeah, from Agnes Rue, we have, she says, my longtime family doctor left his practice last February to go into the private system TELUS Life Plus program, where I would have to pay almost $5,000 annually to continue seeing him. I've not been able to find a suitable replacement GP since then. I do not believe that doctors who practice in such a system should be able to bill our public health care plan for their services and take advantage of all the public system has to offer and pay patients directly. She continues, without trying to replace family doctors with well-meaning but undereducated nurse practitioners, how does the health ministry plan to make sure family doctors are being adequately compensated for their important work and role in public medicine?
Yeah, and Belle, we're going to tackle this growing trend of a two-tier system coming up after the break for the television audience. But right now, you are watching Situation Critical. It's a CBC special examining how the healthcare system in this province does or does not serve people in BC. Private care is one of the topics we're exploring, and if you want to give us a call, you can do that at 1-800-825-5950, or you can email us at bcasks@cbc.ca. Okay, I want to welcome back our television audience. You are watching and listening to Situation Critical, a special CBC presentation on healthcare in BC. We're now on the topic of a two-tiered health system, public and private. Let's go to one of the many emails sent in from our audience now. This comes from Muriel Garland, who has a question for Minister Dix. It centers on his support for a recent ruling dismissing a Vancouver surgeon's challenge of the Medicare Protection Act, preventing patients from accessing private care when wait times are too long. In other words, upholding the province's public health care laws. Now, in response, Garland writes, I deserve the right to spend my hard-earned money on my health care if I choose to do so. Many British Columbians leave the province every year and take their healthcare dollars with them. This money should be spent, she says, at home, reduce the waiting lists, and bolster our public system. Her question, exactly who benefits from this ruling of no private healthcare?
Minister, you regularly defend the public system. What do you make of these comments?
Well, more than defended, this is the most efficient way of delivering care to people, the public health care system. And that doesn't mean there aren't extraordinary challenges. We're, after all, in two public health emergencies. But the people who will lose out if you went to a two-tier system are the people who are the sickest and need care the most in BC. And we have a system, and the important area is one of surgery. I'll just give you a very practical example on MRIs. We used to have it, because we underfunded MRIs in BC. It used to be the case that you could purchase an MRI, then come back in the public system and advance in the wait time. So what did we do? We increased the number of MRIs from 174,000 to almost 300,000 last year in a pandemic. That means that the decision of who gets care is not if Rita can afford it more than I can. She gets care first and I get it second. But the person who needs the care most gets it first. That's the most efficient way to deliver it, and that's what we're going to continue to defend. In the break, we heard from someone concerned about the telehealth proposal, and so what we're doing is following the law. I believe in the Medicare Protection Act, and under that act, it's the Medical Services Commission that makes a decision about whether one goes outside of the rules of Medicare and the rules of the Medicare Protection Act, and they're reviewing telehealth as we speak.
Dr. McCracken, then, about what do you feel about British Columbians being able to pay for private health care when public wait times are too long?
We have a mountain of evidence that shows us that private options make it harder for people to access health care overall. And to Minister Dix's point, it is the people who very often need the care the most who are left out at the highest rates with private. There's no debate about this. We have, as I say, a mountain of high quality research based here in Canada as well as internationally.
Dr. Desange, we'll give you the last word on this.
I think this is a point that all three of us here on your panel tonight can firmly agree upon. I think we all believe in the Canada Health Act, and that if we design a system so robust Everyone deserves health care. Everyone deserves access to a family doctor or a team that can look after their needs. And there should be no exceptions to this. If we create such a great public system, there's no reason to go elsewhere.
It's very interesting that they all come together on one topic.
Absolutely.
Is that going to be the only time tonight?
More than one? Lots more than one.
Yeah. Yes.
Okay, we have a caller standing by on the line. We're going to go to him now. This is Lee Purvis from Salt Spring Island, talking about the problem being bigger than just doctors and nurses. Lee, are you there?
Yeah, hi. How are you doing?
Good, thank you. What's your comment?
Yeah, I'd just like to give the registered nurse perspective. I guess I've been working in Emerge for 16 years now, and I work in a small rural hospital in the Gulf Islands. And, you know, the front line, when we see patients that come in with no family physician, that just swamps our department. And it not only stresses out the nurses that are already short-staffed, but the housekeeping, you know, the lab techs, the x-ray, the whole system just gets swamped. And, you know, I'm 16 years in, and I had to take, even I had to leave my half-time position. That was just too much for me to deal with. And I'm just wondering, yes, it's important for the primary care out in the community for people to have access, but I'm wondering if you're also looking within the system, within each hospital. And, Clearwater is a fine example of that. Emergency room is chronically closed, and I fear that the hospital that I work in is heading in that same direction.
Okay, thank you very much for your question tonight, Lee. Minister Dix, let's put his question to you, his comments to you.
I think registered nurses are essential, especially in our acute care system, but also in the community in ways that our doctors here would absolutely confirm. So British Columbia, in 2017, when I became Minister of Health, we were last in Canada in registered nurses per capita, and that made us very vulnerable. We've led now in new nurses, but we're starting from a lower base. The reality for registered nurses in the community, if you're on Salt Spring or in Clearwater, is that this has been a 2.5-year pandemic. It's been exhausting and it's been stressful. And we're asking more and more of our registered nurses. And what it means for some of them, and this is the challenge we have to face, is that they don't want the full-time position as much. They want to choose. They want to go on casual and choose their shifts more because they've been working so very hard. So what we have to do, I think, together is to recruit more registered nurses. That means adding spaces, like we did in April, 602 nursing spaces across BC post-secondary institutions, and breaking down barriers to internationally educated nurses. There were very significant barriers in place that were impediments to people who wanted to work in Canada and were eligible for work in Canada to work in Canada. And we have to break down those barriers and get going in terms of supporting the nurses we have who are doing an extraordinary job.
Okay, Dr. McCracken, just quickly here before we go to break.
Yeah, we absolutely need to be reforming the work environment. We don't need healthcare heroes. We need healthcare humans is what we need to be able to do. And I think Lee's call just points that out, that you need to be able to go to work and then come home and have a life. And we've all been working in this incredibly stressful environment. It was stressful before the pandemic, and the pandemic just pushed us all a little too far.
Yeah, and we're seeing that with so many sectors across the board, but in healthcare, people, like you said, really have been pushed even further, so I can only imagine. If you've just joined us, this is a special CBC Town Hall Situation Critical. Our TV audience, we're going to take a short break. Everyone else, stick with us. Okay, we are interested in hearing from Indigenous people living in this province. So what does access to health services look like for you and your family? For the moment, we turn to our Wamish Hamilton with an opinion column on the realities for urban and rural Indigenous people during the pandemic.
It is well known that COVID hit the Indigenous community hard. What's less discussed is the damage to people living in urban areas off reserve. More than half of Indigenous people live away from reserve lands in cities. In BC, that population is as high as 70%, according to the First Nations Health Authority. When the pandemic started, Indigenous adults of all ages were prioritized for vaccination. Clinics were set up in remote communities that lacked infrastructure to deal with an outbreak. And many Indigenous people, wherever they live, have underlying health conditions making them vulnerable to pandemics. But we know a majority of Indigenous people actually live in cities. and those underlying health conditions don't shed once they leave the reserve. Yet, while vaccination services traveled to remote communities, meeting people where they were, the access wasn't the same in cities. To date, there have been nearly 21,000 COVID cases amongst First Nations people in BC. More than 11,000 were people who lived off reserve, about 9,000 on. The numbers show the same thing with hospitalizations. Deaths are harder to discern because those numbers appear in a single category. While politicians across the country and in this province celebrated the early vaccination programs for remote Indigenous communities, urban Indigenous people did not benefit from the same ease of access. They were eligible, but not supported in the same ways. I keep thinking back to press conferences from those days and how an incomplete picture was being framed. I recall many self-congratulations. To politicians, I offer this: include urban Indigenous populations when you talk about supporting and serving First Nations. You might have to think twice before breaking your arm, patting yourself on the back, but at least you considered all of us. Wamish Hamilton, CBC News, Vancouver.
Wamish Hamilton points out some challenges facing the urban Indigenous population. There are allegations of systemic racism in the healthcare system. How do we make sure this community is properly served? I'll put it first to Minister Dix, and maybe your colleagues can jump in.
In the middle of the pandemic, we did a report called In Plain Sight that Mary Ellen Derpel-Lafont did for me. I asked her to do it, and for the Ministry of Health, that showed very significant issues that we have to address, fundamental issues for the healthcare system. A woman leaves a prominent provincial hospital in BC 11 times more often if they're Indigenous against doctors' advice, which tells you about a fundamental problem that Wamish was addressing. So how do we deal with it? By putting First Nations health and leadership at the center of the healthcare system. And that's part of why we were successful in part. I know there are criticisms in the pandemic.
And now we have to welcome back our television audience as well. And we'll be able to get back to some comments about this shortly.
Welcome back to our TV audience. This is Situation Critical, looking at the healthcare crisis in our province. And right now we're moving on to the topic of emergency room closures and the pressure that puts on other parts of the system, not to mention the strain on people, patients, and workers.
When you're in a small site like Clearwater, when you lose one nurse for a day, that's half to a third of your staffing for the day, so it has a huge impact. So Clearwater, unfortunately, has seen a lot of closures in the last year. There were several weeks throughout the last 4 months where we were closed overnight most nights, and then a lot of daytime closures as well. We would have periods where we would not have an emergency room open for the weekend. Our staffing is improving, that we're looking to be able to continue that as everyone in our community wants. One of the biggest things we've seen is both fear and some understandably anger. So patients are afraid of, what do I do if the emergency room is closed and I have a true emergency? Not that I've stubbed my toe or cut myself, but the patients who have anaphylaxis and their airway will close without emergency care. Patients who might have a major motor vehicle accident. So they come to the physicians in the office or ask the nurses here, what do I do in that case? And all we can say is call 911 and go to Kamloops. Kamloops is an hour-and-a-half drive at regular speeds. With an ambulance, we can usually do it in just under an hour. I think one of the pieces is for the people in power to make decisions for healthcare, to actually speak to the people who work the front lines and say, what are those issues that you're seeing? Probably we do need more staffing and more training for both doctors and nurses, but that's a long-term plan. If it's not addressed, we are looking at permanent closures of smaller town emerges and potentially even, reduced hours or incredibly long waits for our larger tertiary centers. When you now have thousands of extra patients relying on that center, your emergency wait times there are going to go from 2 hours to 6 hours, 8 hours, and longer.
That's Dr. Kara Purdue. She's an emergency and family physician in Clearwater. Minister Dix, small town mayors have been urging you for months now to do something to keep ERs open and to keep them from being understaffed. What are you doing right now to solve this issue?
Well, the case, there are 3 in particular in the interior, and then a couple on Vancouver Island that have seen a lot of diversions. And it's just straightforward. If you don't have adequate staff at a facility, you have to put it on diversion. And that's what happened. I profoundly think that Clearwater is an emergency room that we have to keep open. And so we didn't do what had been done previously in some cases where move it to a different system or not 24/7, et cetera. We need to keep it going. So we're working with the community, Interior Health is, on permanent solutions. And it does mean that
what are those permanent solutions?
Essentially, providing a better staff. In the case of Clearwater, in the case of Mackenzie, it's really about nurses. It's about Lee's point. It's not about, in those cases, doctors so much as it is nurses. It's putting together a permanent staffing thing to essentially settle the problem. But here's what we have in BC right now. Typically in a week, we have about 8,000 to 9,000 healthcare workers sick before the pandemic. It's been 15,000. And that a week for now, months, for 6 months, really 9 months, since the beginning of the Omicron variant of concern. That makes staffing very challenging in a place such as Clearwater and others, which rely, as the doctors suggested, on a few critical staff. You need a plan to add nursing and to support those communities. Our commitment to Clearwater is that we're going to fix that problem, working with the community and ensuring that doctors are there. And part of the solution in Clearwater, as you know, is a lack of housing there. So starting this coming month, we're going to have also access to housing to allow people to stay there and support the emergency room in Clearwater.
We do have to move on to a question from social media, but I just want to point out, we did have an email from someone who says, she works in Fraser Health, and Fraser Health's sick call records, the number of sick nurses are not the large cause of short staffing. She says we have 4 RNs scheduled to work some shifts where there should be 15 RNs, and this is already including agency RNs, and we are not short-staffed because the government, because of sick calls, but rather because the government failed to retrain and recruit. I do want to get to this social question, though. We've gotten a couple comments on social media now about virtual health care. Sophie made a comment on Facebook. She writes, "My family doctor is okay, but he is afraid to see me in person. Is this policy that virtual appointments are the norm? I have chronic health conditions." Panelists, maybe let's go to Dr. Desange. What do you make of this comment and the fact that some doctors are still wanting to simply continue with the virtual healthcare model?
I would say to you that during the pandemic, we moved to a virtual care model because it was quick and nimble and an efficient way to see our patients, and because there was so much uncertainty of what was unfolding with the pandemic. What I do know is the College of Physicians and Surgeons of BC does have guidelines, and for patient access, majority of our physicians, especially our longitudinal family physicians, are seeing patients in person, and that we know that patients both need inpatient care in clinic services as well as some virtual care. And virtual care is recommended to be attached to a family doctor because those doctors know their patients best. It is difficult to have people that have immunocompromised conditions, or because to the way we're moving forward into our clinic settings, we want to be able to condition our physicians to return back to our pre-pandemic area. However, it's been difficult because, as you know, this collective trauma we're speaking of, and this moral distress and this change, it happened to all of us. And it was an uncertain time, still is at times uncertain, and with the resources as well. Many of the clinics are understaffed, and we can't keep MOAs or frontline staff to be able to staff the clinics as well.
But are you doing anything to ensure that doctors are seeing patients in person and not simply doing everything virtually? Because for some patients, they're raising the alarm about that.
Right, absolutely. And our recommendation has always been to follow our guidelines, which physicians know their professional standards and their ethics and their code of conduct, and that is to provide the best level of care that they know that their patient needs. And that is up to the individual provider. If they see that that patient needs to be seen in person, they'll make that call.
Okay, thank you for that. And Belle, I think you have another question from the phone.
We do. It is from Arlene Tedjo, wants to talk about the impact of staffing shortages on workplace conditions. She's an emergency department nurse at Kamloops Royal Inland Hospital we've been hearing a lot about. Hi there, Arlene.
Hi there, good evening.
What's your question?
Thank you for taking the time to speak with me. I wanted to talk about how I think the BC residents have the right to know the truth that there is a risk when coming to the emergency department. And one of the problems is that the emergency department doesn't have safe working conditions. Just the other day, we had 42 people waiting in line to be triaged with only one nurse to see them all. We're supposed to have a baseline of 15 nurses with only 7 working, and those 7 working are looking after the entire department for 12 hours straight. So we don't have these safe nursing to patient ratios. One nurse is doing the work of 2 to 4 to 6 nurses at one time. Imagine that's your elderly parent coming in next, 43rd person waiting in line, waiting to be triaged by a nurse, let alone waiting to see a doctor. So how does that make British Columbians feel? These circumstances are extremely dangerous for our patients' well-being, as it has been well documented and researched that less nurses equal a decrease in healthy patient outcomes. And I believe in order to change this, simply put, nurses, LPNs, RNs, and all allied health providers need to be paid more appropriately to keep up with inflation. Those who have stayed in their position should receive a retention bonus. Nurses' responsibilities have grown immensely, and we are not dispensable commodities that can be replaced as quickly as people are leaving. Respectfully, I acknowledge that the decision of our decision makers in our health authorities and in the province benefit from significant wage increases. So why not healthcare staff too? If nurses are paid more appropriately, keeping up with inflation, I have no doubt that more nurses and allied healthcare workers would be retained and more would return to work, which would better our work environment in numbers, better our ratios, improve our quality of care and patient satisfaction. So my question to you today is for Minister Dix. It's my understanding that the provincial government has provided health authorities throughout the province with financial support over the years of the pandemic. How are you and your office, Minister Dix, able to ensure that the funding is appropriately allocated and that the health authorities themselves are being transparent with how they're allocating the funding to their employees and the public? I feel I should not have to
Arlene, thank you very much for your question. We have to leave it there, and we'll put that to Minister Dix now.
Thank you.
First of all, Arlene would be represented by the BC Nurses Union, and we're currently negotiating with the BC Nurses Union a new collective agreement, and that's where those issues get addressed. But there's lots we need to do together. I mean, Arlene's working in a hospital that faced heat dome, that faced floods, that faced fires, and that faced COVID-19. There are currently in base beds at Royal Inland Hospital 258 people, spaces, and we have been at overcapacity at Royal Inland, more so than any other hospital in the province, for most of the last year. On average, it's been about 286 people, so they've done an exceptional job. We're obviously working through those things, but we don't just need to negotiate collective agreements. We need more nurses, and that means increasing training spaces. We need to retain our nurses, meaning the exact issues raised by Arlene about our workplaces are critical, including raising and addressing issues of violence. So those are very significant issues. She raised a long question, and I'll give you a bit of a long answer because I think what Arlene raises is really important.
You're watching Situation Critical, a special CBC Town Hall. Those of you watching on TV, we're going to take a short break. If you're with us online or on radio, we'll continue. Turning again to questions we're receiving in social media. We have one from YouTube. User KB asks, does BC have a system that people with chronic diseases get fast-tracked to a primary doctor like they do in Manitoba?
Okay, who wants to do you want to take that, Dr. McCracken?
Sure. So we do not have a centralized wait system. I'm not sure if that is what that KB is referring to. There's a few provinces that have a centralized wait system where you would apply, provide some health information, and then you would be provided a family doctor. We do have several systems within British Columbia that are collecting that information, but it's not being done in a uniform way across the province. And that is something that might potentially help us as a short-term solution when we're facing this shortage of family doctors.
Yeah, because we are seeing, we're hearing from people today, and we've heard from people over the last year, people who do have chronic diseases and chronic illnesses, cancer patients who aren't attached to a family doctor and are feeling hopeless. They don't have any chance of finding a family doctor. Dr. Desange, maybe you want to comment on this.
Yeah, I think to acknowledge how hard it is for our patients and that we feel at times we're really at full capacity. I talk to my colleagues every day and that they've made exceptions to take a few more patients, and they felt compelled to be in that situation where it's actually very onerous to their own health at times. As you've heard, as Lee has even mentioned on the phone, the healthcare human resource crisis is critical, and it affects all of our front lines, and that's our nursing, allied healthcare workers alongside us. But really, it affects our patients. And that is what hurts, is that we don't have a short-term, quick solution to be able to get everybody that's unassigned to a family doctor to be instantly attached. But that is the hope, that if we drive solutions into the primary care, into the community workforce, that we can have hopes of bringing all the physicians that we have in this province to be able to provide that level of care. And we need better working conditions to be able to do that.
And it's one of the issues we've been working on, and we're working on together, Dr. Desange, myself, Dr. McCracken, in different ways to provide better care, particularly for those with chronic diseases. It's one of the issues and one of the challenges with fee-for-service as a system, and why we have to address higher acuity among some patients to allow doctors to care for them. I have type 1 diabetes. I have this experience, right? Lots of people with type 1 diabetes talk to me about their experiences. And as a patient, they can be problematic in a fee-for-service system unless you make changes to that system that support doctors in providing this care. Generally, I walk into an appointment with whatever problem I might have and type 1 diabetes, which makes me a more complex case. And so we have to ensure that doctors are adequately compensated for that and supported as they provide care with people with chronic diseases. And we're working through these issues in detail with the doctors of BC right now.
We need to cut you off there, Minister Dix, as we are going to welcome back our TV audience. If you do have any questions, please give us a call at 1-800-825-5950. Thanks for being with us. This is Situation Critical, a conversation about BC's primary care crisis. Communities across the province face a myriad of healthcare challenges: emergency department closures, ambulance service disruptions, shortage of family physicians and nurses. We've been hearing about a lot of this tonight. And a lot of those staffing issues have to do with recruitment and retention challenges.
I chose to become a nurse because my dad has been a nurse for 12 years, and as a child, he would always tell me stories about his patient experiences, and it made me want to care for patients just like he did. I love everything that I do in nursing. Working with patients is my passion. I love caring for them and working with them and knowing that even the smallest things can help their day and make a positive impact. While doing my 3 placements, I noticed that, well, for one, the nurses were quite short. There were not enough nurses for the number of patients there were in the hospital. A lot of the nurses were running around. They were always doing one thing to the other, and they were always quite stressed because of everything that's going on. There were not enough nurses. There were a lot of patients, and it was just constant stress. It was one of the nurses, she was working all alone. She was just constantly, she had so much work to do, so she would just go from one patient to the next, and she's just trying to get done as much as she can. And I know for me as a student, me and other students were trying to help her with the workload that was left to do because she can only do so much as one nurse. When I was actually there in the clinical setting, I saw how much nurses did, and they went above and beyond what they're supposed to be doing because of how short-staffed we are in terms of other staff in the hospital as well. They do so much for patients, and we don't recognize all of it. Even I didn't before I went into nursing. I think that one of the biggest things in nursing that's really making people leave nursing is because of the fact that they're so short-staffed, nurses under constant stress, and that is not what they signed up for. They went into this career to help people, and instead they are constantly stressed. They're going home burnt out, and they're it's not an easy career because of the fact that we're so short-staffed.
That's Ashna Thupper, a nursing student in Prince George. Now we'll go back to our panel. I have questions for each of you, so let's try to get them in. Minister Dix, we'll start with you. You just heard from this nursing student about working conditions and workloads. How is that acceptable?
Well, it's not. And first of all, we're delighted to have Ashna in the healthcare system, and she's obviously going to do a great job. And we need to add to our nursing complement. It's been 2.5 years, really difficult years in the pandemic, and that's had an impact on both the quality of work and the quality of life of healthcare professionals. And we're seeing some of the long-term consequences of that now. So what do we need? We need a plan that addresses all of the elements of this. We need people who work in the system, who are care aides, want to become LPNs, might want to become registered nurses, to be able to do that. We need to train more nurses, and we have to support the ones we have in the workplace to stay and to address their concerns. Because one of the problems with what Ashton is describing, of course, is that it will lead to someone after a period of time to leave the system, and then you're in a worse situation. So all of that requires all of those solutions. We have added more registered nurses than really at any time in BC's history, but we're still facing significant challenges because they're so valuable in the community and in acute care that frequently you see someone in that situation taking another job with the same health authority with a more regular time frame. And we have to do things to address those issues, particularly in the interior of the province where nurses are facing a particular problem.
You've mentioned a couple of times about new nursing hires, 600, over 600. So Dr. McCracken, 600 new nurses. BC has the largest family residency program in the country, I understand. Why are we still short?
So when you have a gap, we can't just produce more people and put them into the system as it is. We've heard from callers in, we've heard from the other panelists that the system itself needs an upgrade. We are essentially working with a system that was designed in the 1980s when British Columbia really got into the Medicare system. So we not only need to be training new people, but we need to be recreating the work environment so that it's a place where people want to work and can do the work that they were trained to do.
And obviously, we need to attract people. So, Dr. Desange, this agreement just recently that was announced about signing bonuses and 2-year contracts, an offer I understand that was available to the end of this month. It seems like not very many of the 175 residency grads have jumped to take that offer. Why not?
I think the residents also, to Dr. McCracken's point, is that they're determined to do family medicine and to do the work that they were trained to do. However, the working conditions currently have not been able to meet that, and especially the attrition, as we're hearing from our healthcare human resource aspect, we are losing all MOA staff, we're losing nurses in practice as well as the hospital. So I think a lot of the residents that I've heard from are waiting to see what's coming next. I think many are nervous, but they're committed to doing the work for their patients. They're all driven by patient care and they're great advocates, but they also want to see the improvement to working conditions, meaning they do have some fears about the increasing risk in increasing costs of business and how to set up practice in a healthy way to ensure they don't burn out and have to leave expeditiously. Because even my own background, I definitely went in wholeheartedly into full service primary care, but I know that just could not make the business cost work and all the other challenges and difficulties you have. We know that you need a team to support you. So hoping that what we're co-creating with our government now, that moving forward we'll be able to bring our physicians into the workforce, but also retain our physicians that are currently under the circumstances.
Okay, we'll have to leave it there for now. You're watching Situation Critical, a special CBC Town Hall.
The system. Okay, we are now going to go to the phones again. We have Trude Hombre Bueno, who is a patient in Vancouver, with a question about care and walking clinics. Trude?
Yeah, I have an issue with walking clinics that they accept only one health issue per visit. That is very unfair to the patient because if you are elderly, you have more than one health issue to cope with, and they should allow as many as possible, because the patients are elderly mostly, and it's hardship. It means hardship to them that they are only to mention one health issue.
And Trudy, is it fair to assume that you don't have a family doctor?
Well, I have to go to the walk-in clinic and deal with the doctor there.
Okay. Thank you so much for your comment, Trudy. Let's put that now to Dr. McCracken. We see that complaint quite often, that people are saying they can only talk about one thing and they have such a limited time. What do you say to that?
Well, walk-in clinics provide episodic care. That's how they were designed. We had our first walk-in clinic in British Columbia in 1986, which was set up as a corporation to make money. And so they were never designed to provide longitudinal, community-based care. Now, they are fulfilling a very important role right now by providing an access point. But absolutely, Trudy's point that it's not set up to provide her the care that she needs as an elder with more than one health problem. Absolutely. So we need to be looking for an investment in team-based, community, longitudinal care that is going to be able to provide wraparound services for people like Trudy.
Minister Dix, what goes through your mind when you hear someone like Trudy? I mean, I was sitting here listening and I feel bad for her. She's an elderly woman. I can't imagine how hard it is to sit for hours and hours in a waiting room, yet go back again and again. What do you feel?
Well, first of all, the walk-in clinic plays a role, as Dr. McCracken has said. It plays a role in the system. What we need and what Trudy needs is a family practice, what we call longitudinal care, where she gets continuing support over time and can deal with the multiple issues we have.
And when she walks
in, I'm not sure what the circumstances were but of her condition. But say someone is in that circumstance and they use a walk-in clinic. Obviously, that's not adequate. So what we have to do, I think, are two things. One, build out primary care networks. We have 59 of them now to provide more support with our family doctors, our nurse practitioners, and others. That's one. And two, we've got to integrate our walk-in clinics better because they exist, and they better be as connected to the whole system as they can be. And that's what we need to do, both those things, to help people like Trudy.
Okay, I have to let you go there, and we're going to welcome back our TV audience in just a moment.
Thanks for joining us for Situation Critical, a special CBC presentation on healthcare in British Columbia. Now, while we've heard plenty of horror stories, not everyone has had a bad experience in the healthcare system. Tracy Thompson writes, I was just recently diagnosed with breast cancer. 10 days to see a surgeon, 5 weeks for surgery. I am very happy considering all the bad stories in the media.
Okay, so let's put that to all three of you. We want to end the show with sort of your messages of hope, your feelings of hope about the system. Dr. Desange, let's start with you.
I'll just say to Tracy, thank you for that, because it's very meaningful to all my colleagues that have been working tirelessly in the hospital, outside the hospital, family doctors, specialists, our whole healthcare workforce, our nurses, our allied healthcare professionals, everyone that's been trying their darn hardest to keep our healthcare system alive. When we know it's broken, we know it needs work. But let's commit together, all of us, into a solution that's a long-term solution. We can't fix this problem in a 2 to 4 year election cycle. We need to think of a 20-year plan, a nonpartisan plan, that all of us can agree that healthcare is the most vital resource we have, and we need to do our hardest and our best work to protect it. So my biggest gratitude to everyone that's been working so tirelessly. And again, that there is pockets and there are parts of this healthcare system that do work, and that all my colleagues have been committed day in, day out, pre-pandemic and throughout the pandemic, working for everyone. And to recognize, like Dr. McCracken said, that it's not healthcare heroes, but healthcare humans. So Let's try to find that humanity piece back in healthcare, and let's try to strive to make healthcare healthy again. I also take point of our Indigenous people and that our most marginalized populations, they need to be leading, their voices need to be leading and showing us how to provide care. Because
Dr.
when we...
Desange, I have to leave you there because we only have a couple minutes left and we want to get to everybody's messages of hope. Dr. McCracken.
Yeah, I definitely echo what Dr. Desange said. And, you know, being a family doctor is a great joy to me. And I love having interactions with my patients where we solve a problem together and they're able to live a better life as a result of engaging in the Canadian healthcare system. And that's the goal that we should be setting. So in 20 years, if everybody was having an experience like Tracy, what do we need to be doing now in the medium term and the longer term?
Okay, and Minister Dix, we have about a minute left for you. Your message of hope. Your
30
feeling
seconds.
Of hope.
Well, first of all,
30 seconds.
30 seconds, there it is. I'm just, now that's a message of hope. I think, though, real gratitude for the work of our healthcare workers. Last year, we've done more surgeries than ever before by far and reduced surgical wait times, more diagnostics than ever before, more family visits than ever before, more ambulance calls than ever before. But demand has increased dramatically, and people are feeling the stress. People working in the system are, and surely patients are. So what do? We work together hard to make practical solutions all the time. That's what we're going to do to address primary care, and we're doing it starting now.
Okay, thank you so much for all three of you for being here today. Thank you, Health Minister Adrian Dix, Doctors of BC, Ramneek Desange, UBC Assistant Professor Dr. Rita McCracken.
And thank you to those who tuned in on television, radio, and online for this very special CBC British Columbia Town Hall.
You're supposed to say you're Belle Puri.
I'm Belle Puri, but we haven't, we haven't solved problems, but I think we've had some good insight into what is coming forward.
Absolutely, and thank you, Belle, for all the work you've done on this very important topic as well. I am Anita Bathe. Good night, and thank you for watching CBC Vancouver News.
Good night.